Hello, everybody. It's my pleasure to participate in this important educational echocardiography course organized by Cardiology Education Channel in collaboration with International Young Academy of Cardiology and Cardiology Quiz Group. I am Mohammed Adel Abdul Wahab, lecturer of cardiovascular medicine, Cairo University. My topic is about echocardiographic assessment in coronary artery disease. It will be in two parts. Part one, we'll discuss an introduction about the assessment of regional systolic function, either by qualitative or quantitative methods, role of echocardiography in acute coronary syndrome, and assessment of complication of acute myocardial infarction with multiple demonstrative clinical cases. Chest pain can result from many cardiac and non-cardiac causes. The most common clinical cardiac disorder presenting as chest pain is coronary artery disease. Echocardiography has become an established and powerful tool for diagnosing the presence of coronary artery disease and defining its consequences either in patients with acute ischemic syndromes or those with chronic coronary atherosclerosis. Echo has a great diagnostic power to rule out other cardiovascular abnormalities that frequently cause chest pain, including hypertrophic cardiomyopathy, valvular aortic stenosis, aortic dissection, pericarditis, mitral valve prolapse, acute pulmonary embolism, and etc. Assessment of regional systolic function. In echocardiography, regional myocardial function is assessed on the basis of the observed wall thickening and endocardial excursion of the myocardial segment, not simply by noting myocardial motions that may be caused by adjacent segment tethering or overall left ventricular displacement. Regional wall motion may be assessed semi-quantitatively with a scoring system. The most popular current scoring system is based on a 17-segment model advocated by the American Society of Echocardiography, in which each segment is scored as normal, hypokinetic, akinetic, or dyskinetic. The wall motion score index is equal to the sum of the scores divided by the number of segments visualized. Normal wall motion score index score is 1. A wall motion score index of 1.7 is higher is usually associated with physical examination findings of heart failure. However, the conventional visual assessment of regional wall motion abnormalities is subjective, needs highly trained professionals. Also, it relies mainly on judging the myocardial thickening and endocardial excursion, which reflects the radial mechanics of the heart and neglects longitudinal deformation, which is the most susceptible to ischemia. So echocardiography alone may underdiagnose subendocardial infarcts. Here's the grades of regional systolic wall motion abnormalities. Normokinesia is defined as 30 to 50% thickening, systolic thickening of the myocardial wall. Hyperkinesia, which may be a compensatory in case of acute myocardial infarction or in hyperdynamic circulation condition as cytotoxicosis or severe anemia. It means systolic thickening more than 50%. Also, a hyperkinetic response is a normal response in stress echo. Hypokinesia, it means that the myocardial thickening during insystole is less than 30%. Akinesia, no systolic thickening of the myocardial segment. Dyskinesia, when it bulges outward, paradoxically, aneurysm bulge outward with thinning of the wall. Wall motion score is 1 in normokinesia, 2 for hypokinesia, 3 for akinetic segment, and 4 for dyskinetic segment. This is a schematic demonstration for the wall for the myocardial segments in the 4-chamber view, 2-chamber view, and the long axis or apical 3. Here is in 4-chamber view, the posterior septum and the anterolateral wall, basal mid apical segment. This is called apical septum, and this is the apical lateral wall, mid and basal anterolateral wall. 2-chamber view combined from or formed from an inferior wall and an anterior wall. A long axis view similar to the parasternal long axis, anterior septum and infralateral wall. The apex here is formed by the apex of the septum and the apex of the lateral wall. The typical distribution of coronary arteries is the right coronary artery in blue, and the LAD, anterior descending artery, for anterior groove in this baby green light, while the circumflex in the AV groove in the pink color. Can appreciate here the typical distribution of the right coronary involve the mid and the basal inferior wall and the basal posterior septum and the right ventricular free wall. This is the typical distribution of the right coronary. The typical distribution of the LAD involve the apex and the apical septum and the whole anterior wall, in addition to the apical inferior wall and the whole anterior septum. Supplies 2/3 of the heart, the LAD. Circumflex is usually distribution mixed with either the LAD or the right coronary. The anterolateral wall is supplied by either the circumflex or LAD, and mid and basal infralateral wall is supplied by the dominant circulation. The typical distribution for the circumflex is the basal and the mid anterolateral wall, while the mid and the basal infralateral wall is supplied by the dominant coronary artery, either right coronary or circumflex. Here a case demonstration. 76 years old male patient, diabetic and hypertensive, stays post-CABG for 5 years. On initial evaluation, he was non-compliant to his medical treatment with uncontrolled cardiovascular risk factors. He was lost to follow-up, and 3 months later, he developed acute myocardial infarction. So we have a baseline echocardiographic study and a follow-up one after he experienced myocardial infarction. So it's a good case for demonstration of the wall motion abnormalities. Is a baseline echo, normal contraction of the anterior septum and the infralateral wall, and is apical 4 and apical 2 with normal systolic thickening of all myocardial segments. Here is a follow-up study after myocardial infarction. Can appreciate here the infralateral wall becomes hypokinetic, particularly the mid segment. The apical 4, there is significant akinesia of the apical and the mid anterolateral wall. The infralateral wall is almost severely hypokinetic or akinetic. So from this distribution involving the infralateral wall and the anterolateral wall, we can expect that the culprit artery is a circumflex or a large obtuse marginal. Here is a coronary angiography revealed well-functioning lima to LAD. No other grafts could be seen. Subtotal occlusion of large OM, diffuse atherosclerotic disease of dominant right coronary with total occlusion of the posterolateral branch. Quantitative assessment for regional function can be done by either tissue Doppler or speckle tracking technology. Both techniques provide comparable data quality, although Doppler tissue imaging is known to be angle dependent and prone to underestimating motions that is not parallel to the ultrasound beam. Commonly used parameters include velocity, motion, deformation, and deformation rate. However, because velocity and motion are measured relative to the transducer, measurements may be influenced by tethering or overall heart motion. Accordingly, the use of deformation parameters such as strain and strain rate is preferable. The most commonly used deformation parameter is longitudinal strain during left ventricular systole. As we said, myocardial deformation has the potential to overcome these limitations as it is less susceptible to cardiac translation motion and tethering effect of adjacent segments, thus able to differentiate active and passive contractile signals. Simply, deformation means change in the shape while the subject is moving. When a moving object is not necessarily suffering deformation so long as every part of it moves with the same velocity. While deformation occurs when different elements in the same subject move at different velocities, so the object has to change shape during this movement. Strain and strain rate are quantitative indices that have the potential to overcome these limitations. Strain is defined as a fractional change in length of an element of the object when compared to its original length. Here is the original length at end diastole, and this is the length at end systole. The difference between both divided by the original length is called strain. So in longitudinal shortening during systole, the strain value will be a negative value. Strain will be a negative value because the length will be shorter than the original length, so it is a negative value in either longitudinal shortening or circumferential shortening, while in radial thickening, the strain value will be a positive 1. Strain rate is described as the rate of deformation. Again, here is the 2D speckle tracking, frame by frame semi-automated tracking of the speckles in the gray scale. So it is angle dependent, and we can drive the radial thickening or circumferential shortening in short axis views and longitudinal shortening in apical views. As we mentioned before, the radial thickening will be a positive strain value, while circumferential shortening and longitudinal shortening in systole will be a negative value. The more negative the longitudinal systolic strain means more shortening and a better deformation. And here is the strain rate or deformation rate. On the opposite side, the tissue velocity imaging, it needs proper alignment of the Doppler beam, and so it allows measurement only of longitudinal deformation. It's a comparison between both techniques. 2D speckle tracking is a two-dimension analysis measuring natural strain, and it is angle independent, so it measures all deformation parameters, while the tissue Doppler is a one-dimension analysis, measure Lagrangian strain, angle dependent, so it measures only longitudinal and radial deformation. Both are well validated. However, the advantage of 2D speckle tracking is better spatial resolution with less sensitivity to signal noise, less time consuming, but the disadvantage is lower temporal resolution, and it needs a high resolution image quality and the lower optimal frame rate. So this limits the reliability of measurements in patients with tachycardia. While for tissue Doppler, it's less spatial. The disadvantage is less spatial resolution, high sensitivity to single noise, time consuming, but its advantage is high temporal resolution. It doesn't necessitate high image quality, and it can be performed at a higher frame rate. The inter-observer variability for 2D speckle tracking is lower than that for tissue Doppler imaging. Post-systolic shortening or thickening is a characteristic change in temporal pattern of myocardial deformation. This is defined as longitudinal shortening or radial thickening of the myocardium after aortic valve closure. It is a consistent sign of regional functional inhomogeneity. The development of post-systolic shortening during a stress test has been proposed as an indicator of regional ischemia. Similar to global strain, with current technology, regional deformation measurements may vary in amplitude depending on the myocardial region being investigated, the measurement methodology, the vendor, and the sample volume definition. Therefore, no specific normal ranges are available till now. This diagram shows or demonstrate the post-systolic shortening. Here, the end systolic strain, and here is the peak strain, as we noted after the aortic valve closure. The difference is called post-systolic shortening. This case highlights the additive value of 2D speckle tracking to resting echo in predicting significant coronary artery disease. 55 years old male patient, hypertensive smoker, recurrent attacks of typical angina on regular activity for 1 month duration, clinical examination, ECG, and baseline echo was unremarkable. Here we can appreciate there is no significant regional or motion abnormalities at rest in this apical 4-chamber view. Apical 2-chamber view also. Apical 3-chamber view. We have to obtain the 3 apical views carefully with clear delineation of the endocardial border, avoiding foreshortening, adjusting the frame rate, as we mentioned before, ideally around 70. Here, this study is done using a platform, QLab 9, and Echo machine, Philips IE Search 3. Automatically, we just set the 3 points, 2 points as the mitral annuli and the other as the apex, and the software automatically generate and track the speckles in the gray scale and generates the region of interest, and we can adjust it manually if the tracking is not proper. We have to determine the aortic valve closure to set the process automatically. Here is the bullseye mapping, and GLS is significantly reduced, -17 at rest, despite the left ventricular systolic function and the regional systolic function conventionally by visual assessment appear normal. And there is significant reduction in the regional strain also. Here is the coronary angiography. We can appreciate the ulcerated ugly lesion in the proximal LAD and also the obtuse marginal. Here the right coronary is almost free of significant disease. The role of echocardiography in acute coronary syndrome. The use of echocardiography for diagnosis of acute myocardial infarction is most helpful when clinical history and ECG findings are non-diagnostic, particularly in non-STEMI. Echocardiography is a safe, practical, non-invasive, cost-effective rapid bedside test that can be performed whenever possible during chest pain in the emergency room. When a coronary artery is occluded, echocardiography will demonstrate changes in the left ventricular myocardial wall motion within 30 seconds, even before chest pain or ECG changes occur. The presence of regional systolic wall motion abnormalities in patients not known to have coronary disease is a moderately accurate indicator of increased likelihood of acute myocardial ischemia or infarction by pooled data with a positive predictive value of about 50%. The absence of regional motion abnormalities identify a subset of patients unlikely to have an acute infarction with a pooled negative predictive value of about 95%. Segmental left ventricular motion abnormalities are characteristic of myocardial infarction. Their location correlate well with distribution of coronary disease and pathological evidence of infarction. In general, more extensive abnormalities denote an increased risk of complication, including death, recurrent infarction, pump failure, serious ventricular arrhythmia, or heart block, even in patients who appear well clinically. However, regional motion abnormality also can be seen in patients with transient myocardial ischemia, chronic ischemia, as hibernating myocardium, or in myocardial scar. Also, other conditions without coronary occlusion can also cause regional motion abnormalities, but not generally in a clear coronary distribution, such as myocarditis, stress-induced cardiomyopathy, or cardiac sarcoidosis. Although it may not be easy to distinguish acute ischemia or necrosis from previous myocardial infarction, preservation of normal wall thickness and normal reflectivity suggest an acute event. Case 3, 63-year-old lady, female lady, long-standing hypertension and diabetes, ischemic heart disease, previous PCI to LAD 10 years ago, progressive crescendo angina 2 weeks before presentation, or presentation severe hypertension complicated by acute pulmonary edema, ECG, sinus tachycardia, poor progression of precordial R wave, no significant ST or T wave changes. Therapy fast bedside technique after initial stabilization of the patient. And appreciate here the poor echogenic window due to pulmonary congestion. However, we can appreciate there is significant hypokinesia in the infralateral wall with moderate mitral incompetence. Also, there is akinesia of the apex and apical and the mid-anterolateral wall. The anterior wall is less visualized compared to the inferior wall. However, its contractility appear reduced also. Here is the coronary angiography. It's a multivessel disease. However, there is total and stent restenosis of the proximal to mid LAD stents. Also, there is a right coronary angiography. There is significant lesion after the RV branch. Here is after PCI to successful PCI to LAD stent restenosis, and RCA is scheduled for another session. Assessment of complication of acute myocardial infarction, acute mitral incompetence, appearance of a new large color jet of mitral regurg after MI, particularly if turbulent, as indicated by a multicolored signal or directed eccentrically against the left atrial wall, should alert the sonographer to search for structural abnormalities of the mitral apparatus. The diagonal branches of the LAD and the left circumflex both supply the anterolateral papillary muscle, but the posterior descending artery. Usually, a branch of the right coronary artery alone supplies the posteromedial papillary muscle. For this reason, posteromedial papillary muscle rupture is far more common. Rupture of the papillary muscle trunk, head, or chordae will cause the leaflet tip to flail backward into the left atrium with consequent mitral regurg. The jet is usually directed away from the leaflet into the opposing wall. Here in this diagram, ruptured posterior mitral leaflet, flail posterior mitral leaflet result in antarceptal directed mitral regurg, and oppositely, the flail anterior leaflet will cause infralateral directed mitral regurg jet. Colored Doppler jet showing a turbulent eccentric posterior directed wall hugging jet of mitral regurg prosternal long axis view. In patient has a flail anteromitral leaflet. In the setting of acute shock due to mitral valve disruption, patient echocardiographic windows may be poor, caused by multiple factors. Furthermore, poor cardiac contractility overall or wide open mitral valve will also theoretically diminish left ventricle left atrial pressure difference and cause the mitral regurg colored Doppler jet to appear less impressive. A very eccentric jet that hugs the left atrial wall and escapes the usual transducer plane of insonation may also cause under-detection of mitral regurg. So if clinical scenario strongly suggests acute mitral regurg, transesophageal echo should be performed while the patient is being treated supportively and the surgical consultation is underway. Another cause of mechanical complication during acute MI, or another mechanical complication is ventricular septal rupture, occur within fewer than 24-hour post-MI and often precipitate cardiogenic shock. Patients who have had extensive effort delayed or poor revascularization or who have smaller elderly or female are at higher risk of developing ventricular septal rupture. The LAD septal branches supplies the anterior two-thirds of the interventricular septum, while the remaining inferior portion is supplied by the posterior descending artery. Ventricular septal rupture caused by anterior MI tend to be simple, direct perforations through both sides of the septum at the same level and arise more epically, while VSD in the setting of inferior MI are often more complex with multiple serpiginous tracts through septum and involves basal portion of the septum. The area of the defect may simply appear akinetic or thin, or as a discrete area of echo dropout in the muscular septum. Careful sweeping of the transducer plane with color Doppler by tilting the transducer systematically through short axis and long axis planes may be required to detect and localize smaller VCD. Using continuous wave Doppler collinearly with color jet, one can obtain the peak velocity difference between both ventricles. The difference is inversely proportional to the size of the defect. If one documents the patient's systolic blood pressure as a study which should equal left ventricular systolic pressure in absence of aortic stenosis, the right ventricular systolic pressure may be calculated. If undetected, continued interventricular shunting or missed the continuous shunting between both ventricles eventually could cause right side pressure overload. This in turn to lead to pulmonary hypertension and the right heart failure. There have been rare cases of intramyocardial dissecting hematoma occurring as a rare complication of myocardial infarction. This may occur in the septum lateral wall or even the apex and are thought to represent a subacute form of cardiac hemorrhage and rupture that is still confined within the spiral layers of the myocardium. Here, an example of Antarceptal ventricular septal defects of simple type of direct communication between the left and right ventricle, and it is a ventricular septal defect in the basal part of the inferior septum, appears as echo dropout in the tissue from a subcostal view. Pseudo-aneurysm is a ventricular free wall perforation that is totally contained. Pseudo-aneurysms are overall relatively rare, but has a poor prognosis, mortality rate of 21 to 50% in most cases. Most pseudoaneurysms are found after inferior MI and less commonly in the lateral or apical regions. Pseudoaneurysms that occur a few days after acute MI are quite unstable and prone to rupture. The mean time to diagnose pseudoaneurysm is generally in the range of 6 months. Unlike a true aneurysm in which there is thinning of the myocardium, myocardium, pseudoaneurysm is defined as a discrete discontinuation of the 3 layers of the heart with contents of the left ventricle locally contained by adhesions and the adjacent remaining pericardium. In reality, pseudoaneurysm cannot always be definitely distinguished from true aneurysms on echocardiography. Some studies have shown certain characteristics to be more indicative of pseudoaneurysm. Narrow neck, especially less than 50% of the maximum diameter of the aneurysm, ridged edges with an abrupt transition from normal to thin walls, turbulent bidirectional flow by Doppler, intravenous echocardiographic contrast can helpful in the defining pseudoaneurysm. If the patient is stable and there is doubt, cardiac MRI or alternatively angiography with left ventriculogram can also be confirmatory. Is an example of a large basal inferior pseudoaneurysm. We can appreciate here the neck is narrow compared to the long axis of the aneurysm. And here is an smaller apical pseudoaneurysm appear as echo-free space, and contrast echo was helpful in this case to demonstrate spilling of the contrast from the left ventricular cavity to fill this echo-free space, confirming the presence of pseudoaneurysm. Free wall rupture is a devastating complication post-MI due to its acuity of presentation and rapid mortality. This event is rarely captured on echocardiography. Left ventricular rupture has historically been reported to be most frequently detected within 5 days post-myocardial infarction. Similar to other mechanical complications, the incidence has decreased as reperfusion therapy has improved to less than 10% of STEMI cases. In many theories, it is more frequent than septal or papillary muscle rupture. The anterior wall site is the most common site found in autopsies. The findings include acute pericardial effusion in association with discrete focal wall motion abnormality. Typically, there is thinning of the area of the involved section. The actual point of rupture may not be easy to demonstrate without actual surgical exploration due to the slit-like nature of many defects. Intravenous echocardiographic contrast may be useful in demonstrating flow from the left ventricle to the pericardium in small cases. Obviously, this should never impede immediate surgical consultation and should only be considered if diagnosis is unclear and the patient appears clinically stable. Finally, cardiac tamponade as a post-MI may arise from free wall rupture as discussed earlier, or as an iatrogenic complication of cardiac catheterization or surgery. Frank hemopericardium has a distinctive appearance on echo with shimmering vague echo densities within the pericardial sac and should prompt immediate surgical consultation. In case where there is intermittent or stuttering bleeding into the pericardium, adhesions and the fully organized thrombus may also be found within the pericardium. Lastly, post-CABG or other heart surgeries, formed clot may accumulate anterior to the heart and cause right ventricular compression. Such cases may be missed because fully organized clots often have an even, homogeneously echo-dense appearance and can be mistaken for anterior mediastinal tissue, right ventricular myocardium, or pericardial fat. Large pericardial effusion may also be caused by inflammation as a peri-infarct pericarditis, post-cardiac injury syndrome, Dressler syndrome, but tend to occur more gradually over time. Hence, effusions from these causes are far less likely to cause hemodynamic abnormalities. in the acute period post-MI unless they become acutely hemorrhagic. Other causes of cardiogenic shock after myocardial infarction: severe loss of global myocardial contractility due to the infarct itself. In fact, circulatory failure from severe LV dysfunction account for more than 70% of the deaths due to shock following myocardial infarction. Right ventricular failure due to right ventricular infarction or pulmonary embolism that may accompany and exacerbate overall heart failure. Rarely, left ventricular outflow tract obstruction can occur in patients with distal LAD infarction with compensatory hyperkinesia of the basal left ventricle, particularly in patients with focal upper septal or asymmetrical septal hypertrophy. This will contribute to a drop in cardiac output. Post-MI and the blood pressure may paradoxically and dramatically drop after any drops. This is a case about a 54-year-old male patient, smoker, complaining of typical chest pain for 14 hours, presented late to the emergency room with extensive anterior MI, ST elevation 1 and AVL, and from V2 to V6. Patient transferred directly to cath lab, and you can appreciate total occlusion of the mid-LAD. Right coronary is patent. Wiring was smooth, with no events. And as expected, no reflow occurred, and this is the final result. Although the LAD is opened by the stent, the myocardial blush is poor. This is due to microvascular obstruction. And post-case, there is no significant resolution of chest segment elevation, and patients continue to complain of chest pain. And this is the echo post in the CCU. You can appreciate the severe LV dysfunction, and there is a rim of pericardial effusion. Here, our differential diagnosis: either it's iatrogenic due to wiring or coronary perforation, or it is a part of myocardial rupture. Particularly, there is a predictors of free wall rupture, as the LAD revascularization was not successfully. Unfortunately, IV contrast was not available. We used the color Doppler, and we may suggest continuity between the left ventricular cavity and this pericardial sac. The patient's hemodynamic deteriorated rapidly, and there was no time for cardiac MRI, and the cardiac consultation, surgical consultation was done, but unfortunately, patient arrested while preparing him to surgery. This is the end of our the first part of this lecture, and thank you for your attention.